Hello, we're glad you've joined us for this live webinar, Heart Failure, a Global Challenge from Prognosis to Management. I'm Susie Valdez of LabRoots, and I'll be your moderator for this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by Abbott. Abbott helps people live their best life through the power of health. For more than 125 years, they've brought new products and technologies to the world in nutrition, diagnostics, medical devices, and branded generic pharmaceuticals that create more possibilities for more people at all stages of life. Today, 94,000 Abbott team members are working to help people live not just longer, but better in more than 150 countries. To learn more about our sponsor, please go to www.abbott.com. So let's get started. You can pose questions to speakers during our presentation while they're fresh in your mind. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of your presentation window. If you experience technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of your presentation window, or report your problem by typing it into the Answer a Question box located on the far left of your screen. Also, we will be conducting some polls during this presentation and would really appreciate your participation. The polls will pop up in your slide window. When it pops up, please click on the answer that best reflects your work. Thank you again for participating in advance. This is an educational webinar and thus offers free continuing education credits. Click on the Continuing Education Credit tab located at the top right of your presentation window and follow the process for obtaining your credits. I'd now like to present today's speaker, Dr. Peter McCullough. Dr. McCullough is the Vice Chief of Medicine at Baylor University Medical Center in Dallas, Texas, and a principal faculty member in internal medicine for Texas A&M University Health Science Center. He is internationally recognized authority on the role of chronic kidney disease as a cardiovascular risk state with over 1,000 publications, including the interface between renal disease and cardiovascular illness in Braunwald's heart disease textbook. Dr. McCullough is a recipient of the Simon Dack Award from the American College of Cardiology and the International Vicenza Award in Critical Care Nephrology for his scholarship and research. He is also the founder and current president of the Cardiorenal Society of America. His work has appeared in the New England Journal of Medicine, the Journal of American Medical Association, and other top-tier journals worldwide. He is the co-editor of Reviews in Cardiovascular Medicine, associated editor of American Journal of Cardiology, and serves on the editorial boards of multiple specialty journals. Dr. McCullough's complete bio can be found at our website, LabRoots site, labroots.com. Please join me now in welcoming our presenter, Dr. McCullough. You may now begin your presentation, sir. Welcome.
Well, I want to start out by thanking you for that introduction and thanking our sponsor today, as well as all of you who've joined the call for this important webinar titled Heart Failure, a Global Challenge from Prognosis to Management. And I just want to say as an opener that heart failure is our most important diagnosis from a hospitalization perspective in the United States. It's the leading cause of hospitalization and a central focus on internal medicine physicians, hospitalists, cardiologists, hospital administrators, and many others with respect to this really chronic disease pandemic that we are facing. Our topic today will bring up important points with respect to the clinical laboratory and its role in heart failure. So with that, I want to give a disclosure that this speaker program is sponsored by and on behalf of Abbott, and the content of the presentation is consistent with all applicable FDA requirements. I have received consulting fees from Abbott Diagnostics in the past. So I'll follow this outline and make a few comments with respect to each one of these bullet points and get us opened up to the idea of heart failure, discuss the challenges that this syndrome presents, get into the utility of natriuretic peptides, these important diagnostic as well as prognostic and management tools that we have, and then present Collectin III. That may be a particular test or an assay that you are less familiar with, and then wrap it up with conclusions. Well, what is heart failure? It's certainly not a good term to use with patients. Patients are always concerned. Many hospitals have heart failure services, and they've really struggled with this and have tried to change it to heart success services or use some other type of term. But what we know is that a definition of heart failure, a modern definition, would be that heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the left ventricle to fill or eject with blood. Because not all patients have volume overload at the time of initial or subsequent evaluation, the term heart failure is preferred over the older term congestive heart failure. And I think that's an important take-home point. We use the abbreviation HF as opposed to CHF. Now, of all the heart failure types that exist, we can divide them into about half are patients who have a reduced left ventricular ejection fraction. The left ventricular ejection fraction is the amount of blood that's ejected with each beat of the heart from the left ventricle out into the aorta. And what you need to know is that about half of patients have a reduced left ventricular ejection fraction. A normal value is 55 to 75% of the blood is ejected with each beat, and when it's below 45%, experts would agree that it's reduced ejection fraction. About half of patients, though, the ejection fraction is preserved, and so we use this term reduced and preserved LVEF. Now, the ejection fraction is determined by cardiac ultrasound echocardiography, can be determined by nuclear scintigraphy, can be determined by cardiac catheterization, but it's a core measure that all hospitals know the left ventricular ejection fraction by these imaging studies for not only management of heart failure, but also patients after myocardial infarction. Of those with reduced ejection fraction, about 2/3 have an ischemic etiology, meaning they've had a prior heart attack and damage to the heart. About 1/3 are considered non-ischemic. Of those with preserved ejection fraction, about 25% of patients have superimposed ischemia, and we don't understand its importance in terms of its contribution to the left ventricular dysfunction. About 75% of that subgroup have no evidence of ischemia when subject to stress testing. What we know is that heart failure with preserved ejection fraction is difficult because here the ejection fraction is normal or near normal, and that when we look in a large clinical trial like this one, the iPreserve trial, that you can see about 45% of patients have no evidence of left ventricular hypertrophy, that about 34% have a normal left atrial size, and 31% have normal diastolic parameters on the Doppler examination. So heart failure with preserved ejection fraction really can't be established with echocardiography alone. It's a clinical syndrome that's very much dependent on support from the clinical laboratory. Years ago, I published the largest heart failure study in the world called the REACH study, and it had nearly 30,000 patients that were followed over 10 years. And what we demonstrated was that clearly the incidence of heart failure was age-dependent, as you can see in the left-hand panel, where individuals, as they go from below age 65 all the way through greater than 85, have a progressively higher incidence rate. Men and women are pretty close. And then what you can see on the right-hand panel is that the age of diagnosis is strongly related to survival. As a general rule, heart failure has a 5-year, 50% survival and has only a 10% 10-year survival. The vast majority of patients, about 90% of patients with heart failure, will die of heart failure. And the mode of death is either pump failure or sudden electrical arrhythmic death. But we always teach the students and house staff and others, nurses, that when a patient has heart failure, that should be the number one diagnosis on the problem list, since it will dominate the patient's healthcare utilization, and it will be very likely the cause of death in the end. Now, the American Heart Association has stages of heart failure, stages A, B, C, and D, and that really has to do with a consideration of the where a patient is in the heart failure continuum. Stage A means there's no manifestations of heart failure, but risk factors are present, such as hypertension or structural heart disease. Stage B is where patients have a reduced ejection fraction, but they don't yet have symptoms. Stage C is symptomatic heart failure with its cardinal features of shortness of breath, peripheral edema, and fatigue. And stage D heart failure is considered terminal heart failure. We know that, and the guidelines suggest that early recognition and treatment are the key. If we diagnose heart failure early and we start appropriate therapy, we can markedly change the outcome in patients. Our pharmaceuticals and devices really do work, particularly for low ejection fraction heart failure. We have over 12 forms of therapies that can be applied that reduce hospitalization or death. Unfortunately, we don't have the same for heart failure with preserved ejection fraction. And then largely, end-of-life care really matters. Here, we oftentimes involve hospice or palliative care in the very end stages of disease. Now, what are the challenges that exist with heart failure given what we know? Well, the total population is estimated at about 6.5 million, and there's nearly 1 million new cases per year. You can see that 50% 5-year survival and the overall costs, which are really large. The major cost driver, though, is the incidence of hospitalization. It's really not our utilization of drugs or devices, therapies, imaging diagnostics or laboratory diagnostics in the clinic. Those are all very small in comparison to the cost of hospitalization. So it's always been said the goal in heart failure is to avoid these hospitalizations. It's a burden for patients because of congestive symptoms, activity limitation, the abnormal heart rhythms, these recurrent hospitalizations, and reduced survival. The majority of my patients with heart failure unfortunately go on medical disability or medical retirement and really are busy with their hospital visits and medical therapy. You can see it's projected by 2037 that we're going to have about 10 million individuals with heart failure. And the projections from my original REACH study are being applied here, that we're really on the ascending limb of a curve, primarily because the age structure of the United States is changing to a more elderly population. The lifetime risk of heart failure is about 1 in 5 for men and women, and that's largely driven through the principal risk factors of hypertension and coronary heart disease. Both of those root causes have a large preventive aspect to it. So with perfect blood pressure control and perfect coronary heart disease risk factors, one could guide themselves to a much lower risk of heart failure over the course of their life. The prognosis I've already mentioned with respect to survival over time, about 40 to 60% of patients do have very severe symptoms that are limiting them. You can see that the prognosis of patients is similar to that of patients with certain cancers. And although we have a much different approach to patients with cancer in terms of our access to services and our general empathy, it's important to realize that a diagnosis of heart failure is about as severe as many solid organ cancers. The long-term trends in heart failure survival are somewhat favorable, and you can see here that there's progressively lower rate ratios for the incidence of heart failure in men and in particularly in women. So we are making progress with respect to blood pressure control and other risk factors attenuating this graduation rate to heart failure. You can see here that the overall temporal trends and the age-adjusted mortality rates are not changing over time. And this suggests that once patients have a diagnosis of heart failure, we haven't been moving the needle with respect to mortality. Now, the survival trends in heart failure can also be looked at in terms of age or calendar temporal periods. from 1987. You can see forward to 2001. At least during that period, unfortunately, it was stagnant with a lot of developments, and so we didn't see an improvement in survival. Now, in hospital length of stay is about 6.2 days, and the mortality rate's 4.1%. Hospital readmission rates are about 20% at 30 days. This is a key metric because hospitals that are above a moving average here do receive a penalty from Medicare if this occurs. But 50% of patients are hospitalized at 6 months, and you can see the longer-term mortality statistics. And I can update you that it's been presented this year that the Medicare penalties for readmission have not lowered readmission rates nationally. And in fact, since they've been put in place, mortality rates have gone up. So many thought leaders are really bringing out the point that public policy does need to be linked to improved outcomes. And when improved outcomes don't occur, we need to really reevaluate that policy. Many hospitals are paying penalties right now, and there's no suggestion that those penalties are working in terms of reducing hospitalization. So we're at our first polling question, and a survey slide will come out to you that will ask the question that please select which biomarker do you or your institution currently use to manage heart failure patients. BNP, Nterminal Pro BNP, Collectin III, or none. And I'm hoping the question will allow you to choose more than one. But I'm going to go ahead, as you tackle that, I'm going to go ahead and move forward. So let's get into the natriuretic peptides. These are hormones produced by the heart muscle that are measurable in blood and have been used to rule out heart failure, aid in the diagnosis of heart failure in cases where the diagnosis is uncertain, and then they're very powerful in terms of prognosis and risk stratification. This slide shows a schema of a cardiomyocyte shown on the left in yellow, and then the plasma shown in the right in a white background, showing that cardiomyocytes, both atrial and cardiomyocytes, produce Prepro BNP. The gene for this is coded on chromosome 1. It has a very rapid upregulation sequence, so the heart can produce a lot of this on demand in response to wall tension. It secretes Prepro BNP. It's initially cleaved by furin in the cardiomyocyte, and then outside the cardiomyocyte cleaved by an enzyme called corin into two fragments. One is the inactive N-terminal Pro BNP fragment, which is 78 amino acids, and the other is the mature BNP fragment, which is 32 amino acids. It's very important to realize that N-terminal Pro BNP has a much longer half-life, 120 minutes, compared to BNP, which has a half-life of 20 minutes. N-terminal Pro BNP is cleared by the kidneys and into the urine and does undergo some proteolytic cleavage. BNP is largely cleared by clearance receptors that are in all solid organs, including the kidneys. BNP is not filtered into the urine, and it also has some clearance from neutral endopeptidase. So all the assays for BNP agree that the upper limit of normal is 100 picograms per ml. For N-terminal Pro BNP, there's no agreement among studies with single assays, or there's no agreement between different assays of what an upper limit of normal is. As a general rule, an upper limit of normal could be viewed as less than 450, but that's far greater than the FDA package insert. So with N-terminal Pro BNP, it's just really a relative judgment without hard cut points for normal versus abnormal. BNP, it's very different, where we have got a singular cut point, which holds at 100 in all studies. And that was initially shown in this paper in New England Journal of Medicine, the BNP multinational study, where in 1586 patients who presented to the emergency room with suspected heart failure, you can see here BNP had an area under the ROC curve of 0.91. The cut point fell right at 100 picograms per ml, and it was a very clear signal that when patients had symptoms attributable to heart failure, the BNP was reliably elevated. Conversely, when heart failure wasn't present, BNP less than 100 reliably ruled out the presence of heart failure. It's been further shown that in the setting of acute coronary syndromes where there can be left ventricular dysfunction, that no matter if the patient is troponin negative or troponin positive, those with an elevated BNP value have a much higher mortality at 30 days. Now, the reason for these fatal cases is that BNP is reflecting large zones of ischemia, severe left main coronary lesions or severe three-vessel coronary disease, large myocardial infarctions, pre-existing left ventricular impairment, systolic or diastolic dysfunction, or renal dysfunction. And none of these things are favorable for the patients. But the point is BNP should be measured in patients with chest pain and acute coronary syndromes. I know at Baylor we do this now, but several years ago we didn't. It took a long time for everyone to get caught up with the guidelines. And BNP is a Class 1A indication for all patients with heart failure and all patients with acute coronary syndromes. Now there is a continuum of BNP that you can think of in patients. All of us who are hopefully without heart failure or perhaps just with a risk factor for heart failure like hypertension, the BNP should be less than half of our age. So if you're under age 50, hopefully it'll be less than 50 picograms per ml. Stage B heart failure, there have been screening studies suggest for sure BNP will be over 20, but in general BNP can be much higher, over 100 or so in patients with structural heart disease. Stage C symptomatic heart failure, BNP is relatively reliably over 100 when patients present to the clinic. It can be 500 to 5,000 with decompensation. We do know about a quarter of patients with stage C heart failure optimally managed can achieve a BNP below 100. And then lastly, stage D heart failure, my experience is that the BNP is typically over 1,000 and is not coming down with therapy. There have been multiple clinical trials using BNP in the management of patients, and it has been shown to be associated with reduction in mortality if BNP is used in the outpatient clinic on a regular basis to help assess where patients are in terms of their multi-drug therapy, and its use is associated with reduced mortality in this meta-analysis. And then importantly, all of these studies that have been associated with BNP and positive management outcomes have been specifically with the BNP assay and not the N-terminal Pro BNP. And in this head-to-head analysis that I published years ago, you can see that BNP has a tighter dynamic range than N-terminal Pro BNP, but importantly, a much smaller gray zone. The gray zone in BNP could be between 100 and 500 on in certain cases, but with N-terminal Pro BNP, it could be 450 to 2,000. N-terminal Pro BNP does not have a stable cut point from assay to assay or from study to study, and for that reason, it can be used to get as a general guide, but we cannot apply hard cut points or cutoffs to N-terminal Pro BNP. I want to finish with some comments with respect to Collectin III. This assay may be one that you're not familiar with in your clinical laboratory, but it also is FDA cleared and is part of the guidelines for patients with heart failure. What we know is that heart failure is associated with what's called adverse remodeling, and the heart muscle tissue does have macrophages. Believe it or not, in heart tissue, about 2/3 of the cells are not cardiomyocytes, but there are other satellite cells such as macrophages, which are resident in heart tissue. And we know that that macrophages can secrete Collectin III in response to various stimuli, and the Collectin III then stimulates fibroblasts to proliferate and then begin to secrete procollagen 1. Procollagen 1 then cross-links to mature collagen, and that actually is what causes scar or fibrosis in heart tissue. We do find that the heart does develop fibrosis. The galectins are normally in tissue and they're present as important signals between macrophages and fibroblasts in order to cause healing. So when the skin is cut and a scar forms, it's all mediated through Collectin III, or through galectins, and there's a whole family of them. But in the heart, specifically, Collectin III is produced by these resident macrophages, and and all studies suggest that it's a maladaptive signal that the Collectin-3 is actually pathogenic in the development of heart failure as a syndrome. So let's get into it. What is known about Collectin-3? Well, it's one of a family of lectins. There's about 11 of these. Its gene is known. It's been sequenced and cloned. It's the most upregulated fibrosis-related protein in the myocardium of the failing heart, secreted primarily by macrophages. It's a paracrine or autocrine signal. It's rapidly internalized by beta-1 integrin on the cell surface of fibroblasts. It can form pentameres at the cell surface and activate growth receptors. Its main target is myofibroblasts via intracellular signaling, and this helps translate the TGF-beta signal to increase the cell cycle. So basically, it's revving up myofibroblasts and fibroblasts to secrete procollagen 1. It's proven to be pathogenic. It induces fibrosis in animal models, and it has a natural inhibitor called ACSDKP. This inhibitor protein is slightly upregulated by ACE inhibitors, as an example, and it's also contained in citrus pectin. So eat your oranges and your citrus fruit is thought to be an inhibitor of this fibrotic process. Here are the data showing that Collectin-3 is directly pathogenic in this paper by Sharma. And what was done in this study is that animals had the pericardium opened, and the heart was basically bathed in synthetic Collectin-3. And what was shown is that those animals where Collectin-3 was induced developed heart failure at a much higher rate compared to those who didn't. What we've shown in the PREVENT study is that a normal population of Collectin-3 level settles in around 10 to 11 nanograms per ml. There isn't a hard declaration of normal in the available assays on the market, but this population-based study suggests that Collectin-3 goes up a little bit with age. But very importantly, shown in the Framingham Heart Study, that individuals in midlife whose Collectin-3s were over 15.4, that they had a markedly increased risk for the development of heart failure compared to those with lower Collectin-3 levels. And so my understanding of the data is that this is the most powerful predictor for the future development of heart failure that we have as a blood test. And its prognostic ability to anticipate heart failure in the future is very strong. It is indicated to be used in patients with established heart failure based on these data from the COACH study, where, as you can see, through a range of Collectin-3, the overall risks for death and hospitalization are progressively higher. Now, granted, all patients with heart failure, even at lower levels of Collectin-3, have increased risks of these events, but you can see at Collectin-3 over 25.9 would be considered very high, and at that level there's a considerable short-term risk of death, which is even greater than that of hospitalization. Now, it's been shown from 2 trials where the data were merged that Collectin-3 doesn't move very much in heart failure patients. It moves at as much as a 15% change when measured 9 months apart. So it doesn't change very much, but when it does increase, the prognosis is worse, as shown on that green line, and when it does decrease, the prognosis is better. However, Collectin-3 in my practice is something I typically measure on the initial consultation and maybe a year later, but it's not a test that's amenable to very frequent testing, unlike BNP values, which can be measured in studies up to every 6 weeks and show value. Now, Collectin-3 has been shown in experimental models to be related to renal fibrosis, and in this study, these animals had what's called a ureteral outlet obstruction model, that in the wild type, as shown in the left-hand panel, Collectin-3 is markedly upregulated and there's collagen deposition. But when we knock out an animal for Collectin-3 and they can't produce it, there's considerably less fibrosis that's developed. So we do know in kidney disease that Collectin III is playing a role. And we published a paper several years ago suggesting that probably there's simultaneous cardiac and renal fibrosis that's occurring and is explaining some of the chronic cardiorenal syndromes where patients have simultaneous heart and kidney failure. The Collectin III may be playing a pathogenic role. We do know from the Framingham heart study that Collectin III is related to a reduction in glomerular filtration rate over time, meaning progressive chronic kidney disease. So just like it anticipates heart failure, it anticipates chronic kidney disease, but it does not predict albuminuria. So remember, for chronic kidney disease, we still need to measure the serum creatinine, calculate the estimated glomerular filtration rate, and also measure the urine albumin to creatinine ratio. Collectin III does have this important relationship. The cut point for progression of chronic kidney disease in Framingham is very similar for the progression of heart failure. It's greater than 15 nanograms per ml. Well, I want to now move on to the conclusions, and we'll have some more questions, and finish by saying that heart failure is a clinical syndrome which is amenable to the use of in vitro diagnostics. Natriuretic peptides indicate increased wall tension, both BNP and Nterminal Pro BNP. In my view, BNP offers a more interpretable framework with a teachable algorithm and has had positive studies with respect to management outcomes. The same is not true for Nterminal Pro BNP. Collectin III is a mediator of cardiac fibrosis, and it's measurable in plasma, and it is a prognostic aid in heart failure. BNP and Collectin III can be used in assessing the response to therapy. BNP is a lot more responsive than Collectin III. But these and other novel markers may become targets for disease management in the future. I think they clearly have a role and have helped clinicians since their introduction now, the natriuretic peptides being introduced nearly 20 years ago. So I'll stop here, and we'll turn it over to our next polling question.
Thank you, Dr. McCullough, for your presentation. A quick reminder to our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window, labeled Ask a Question, and click that send button. Dr. McCullough will answer as many questions as time permits. So let's take a look at our incoming questions already from our audience members. Our first question, Dr. McCullough, is there a difference in incidence of arrhythmia in reduced versus preserved EF mortality differences?
Yes, there are. That's a good question. The risk of fatal arrhythmias is higher with heart failure with reduced ejection fraction, and it's for that reason when the ejection fraction is less than 35% that implantable cardiodefibrillators are indicated. And that's the reason why ICDs are used in heart failure with reduced ejection fraction, and they largely are not used in heart failure with preserved ejection fraction.
Thank you very much. Our next question is, are there any other heart failure biomarkers beyond natriuretic peptides and Collectin III?
Yes, there's a third biomarker called ST2. And that stands for the suppressor of tumorigenicity 2. Much less is known about this. It was originally discovered in the cancer literature. It turns out that the cells inside the left ventricle and the aortic outflow tract secrete ST2, and it acts as a decoy protein interfering with the immune signaling between the immune system and cardiomyocytes. But much less is known about ST2. It appears to be prognostic in heart failure. And in general, what we've learned is that these tests are very complementary to one another. They help us understand different aspects of heart failure. So I anticipate ST2 will be used in complement to BNP as well as Collectin III.
Thank you for that. And thank you to our audience members for submitting these great questions. Our next question is, what is the percentage of Collectin III used for heart failure versus BNP Nterminal Pro BNP?
My understanding is the majority of testing is really with BNP or N-terminal Pro BNP, and it comes out of the emergency room, which is appropriate because all patients who present to the emergency room with suspected heart failure should have one of those tests done. Collectin III is used less often, and in my view is more of an office tool in the initial office evaluation of a patient with heart failure, where again I order a BNP, but I also order a Collectin III, and I'll say in my practice I do also order an ST2. I order a fourth protein that everyone's familiar with, and it is in the heart failure guidelines, and that's troponin, cardiac troponin. At our hospital we measure cardiac troponin I, but either troponin I or T can be used. So there are 4 guidelines recommended tests for the office evaluation of heart failure, and they are BNP or N-terminal Pro BNP, Collectin III, ST2, and cardiac troponins.
Thank you, Dr. McCullough. And which of these biomarkers do you currently use in your practice to manage patient therapies? What change are you looking for to confirm are working or not working?
Well, the most successful biomarker in practice for management has been BNP. And we know there that when BNP doubles from wherever it is, the patient clearly has worsened. And we know if BNP is reduced by 50%, the patient clearly has gotten better. And I think we have to use those wide boundaries to really understand BNP in guiding therapy. So if I have a patient in the office whose BNP is doubled, that's a pretty strong signal to the patient. We need to get that patient in and adjust their diuretics, oftentimes give them a short course of an increased diuretic to get them back to a good volume status. Conversely, if the patient's BNP is dropped by 50%, that's a signal that we probably can down titrate diuretics and make some other adjustments. Maybe we have more room with respect to blood pressure. We can increase some of their disease-modifying therapy like an ACE inhibitor, an ARB beta blocker.
Thank you. And why have the readmission rates not gone down despite penalty to the hospitals?
That is a terrific question. Right now there are not good sources of explanation for that observation, but my personal concern is what's happening is that there has been a great effort to try to reduce these admissions, and by doing so, we may be shortening the patient's hospital stay, or we may be prompting more surveillance of symptoms in patients coming right back into the hospital for more treatment. It's pretty clear that our therapy that we apply in the hospital does not modify the disease. We simply, in a sense, kind of tune up heart failure, and then patients can come right back in. So our treatment is not durable, and we don't have any FDA-approved, proven inpatient therapies. And for that reason, it would make sense that we, even if we're penalized, we still can't make headway in this disease state. There were prior studies that I think misled us, that suggested that some of these heart failure readmissions were avoidable. And right now, the data suggests that they're not.
And Dr. McCullough, is there any evidence of improved prognosis using Collectin III in cardiac fibrosis patients?
Yes, it's clear that when Collectin III drops over the course of a year by more than 15%, the patient is on a good course. And sometimes we see patients have dramatic improvements with some newer medications. One of them is called Entresto, which is a drug that's superior to ACE inhibitors in the treatment of heart failure. Sometimes we see patients who have forms of non-ischemic cardiomyopathy where they markedly improve with a whole constellation of drugs, including Entresto, evidence-based beta blockers, the use of a new drug called ivradibine, that in that setting, if Collectin III really reduces and takes a good downward trajectory over time, then patients may have prolonged survival. All the data suggests that's the case. So that's good news when we see Collectin III dropping.
Thank you. And what is the cost and time frame receiving for results using Collectin III? How can we make it more widespread?
I don't have the answer on costs because the laboratories all have, their own contracts and techniques on doing these assays. Some laboratories do them in-house. Some of them send them out. I can tell you in our practice environment at Baylor that these are a very minor part of the cost picture for patients. So they're much less expensive than getting additional imaging or doing additional testing. The lab is our best value, if you will. The use of laboratories in general is lagging across many quality metrics. So for instance, diabetics do not get enough hemoglobin A1C testing. We have data that in adults and children, we don't do enough lipid profile testing. And then, as the question implies, we don't use enough evidence-based testing in heart failure and acute coronary syndromes. So I think we have a long ways to go to use these important laboratory tools to their optimum capabilities. And it's one of the reasons why we have seminars like this.
Thank you. And I want to thank our audience again for their wonderful participation and their incoming questions. Are there any other biomarkers apart from Collectin III for patients suffering with cardiac fibrosis? No, outside of the 4 evidence-based markers are BNP or Nterminal Pro BNP, Collectin III, ST2, and cardiac troponin. Those are the 4 that are FDA cleared and that are in the F.A.C.C. 2013 guidelines. There are many more biomarkers that are under research evaluation right now, and that list is quite long of tests that are under research that are measurable in the research setting. But all of those will have to be borne out in studies that show that they're both accurate, that they're precise, and that they have a clinical utility. Most commonly, the clinical utility that would win an FDA clearance would be Prognosis. And so far, beyond the 4 I've mentioned, none have additionally won an FDA prognostic claim. Now, does Collectin have to be used for other cardiac markers to give diagnosis for HF? No, Collectin III on its own, it has important prognostic value. I can tell you in my practice, I almost always order it with the other evidence-based biomarkers, but it alone and by itself has prognostic value. And I think uniquely, Collectin III is the strongest of all the markers in terms of predicting the future development of heart failure in patients in middle age. And so Collectin III is provided on a advanced laboratory panel that I use in my office practice. And so in that application, it does give me an important window to the future in terms of future risk of heart failure. Thank you. And this next question is a 2-part question. In a patient with diastolic dysfunction due to irradiation, show a higher Collectin III, or is Collectin III equally as important in preserved and reduced ejection fraction? Yes, my experience is that Collectin III will be elevated in forms of radiation and chemotherapy-induced cardiomyopathy. And yes, it is prognostic and elevated in both types of heart failure, preserved and reduced ejection fraction. And does Collectin III values change your management of the patient? And if so, how? Yeah, I think that the Collectin III values, and this is an extension beyond what's in the current guidelines or beyond
the FDA package insert, but I can just tell you my practice pattern is that the data suggests that Collectin III markedly elevated patients, in my view, need intensification of their medical therapy along the lines of ACE inhibitors, angiotensin receptor antagonists, the new combination of valsartan and sacubitril, and then mineralocorticoid receptor antagonist, spironolactone or eplerenone. And there have been some prospective studies that the drugs that I just mentioned, that they work optimally in helping attenuate the progression of fibrosis. So when Collectin III is elevated, I'm thinking about cardiac fibrosis, and I'm thinking about that whole line of medications, which is very, very different than other lines of medications we can use in heart failure.
Thank you. And Dr. McCullough, how is HF with preserved EF diagnosed?
Heart failure with preserved ejection fraction clinically looks very similar to heart failure with reduced ejection fraction. The patients have fatigue, they have shortness of breath, they have evidence of fluid in the lungs, and they have peripheral edema. It's just that when we do the cardiac echocardiogram, the ejection fraction is normal, and many times there we're reliant on the BNP, that the BNP or the N-terminal Pro BNP helps establish the diagnosis. Now, the BNP in general won't be as high as those with reduced ejection fraction, but it'll be well above that 100 picogram per milliliter cut point. So if I see a patient who is short of breath, they have pulmonary edema, peripheral edema, and they have a BNP of 500, that basically clinches the diagnosis of heart failure with preserved ejection fraction.
Dr. McCullough, you discussed the differences between Nt-Pro BNP and BNP biomarkers, and we've seen discussions and concerns surrounding glycosylated samples in HF patients and Nt-Pro BNP's inability to cross-react with these samples. Can you comment on the frequency and impact of glycosylated samples and their impact of accuracy of diagnosis?
Well, let me just state that all proteins in the human body can undergo glycosylation. So, for instance, I mentioned everyone on the phone is familiar with glycosylated hemoglobin or hemoglobin A1C. We measure that, but albumin can get glycosylated, as well as the question points out that natriuretic peptides can get glycosylated. What I understand about it is that both of these peptides, BNP and N-terminal Pro BNP, are sufficiently stable over time in blood that they're measurable. And they're measurable from stored samples and from shipped samples. So from that perspective, that the values have certainly been vetted in prospective clinical studies, despite some degree of glycosylation. Beyond that, I refer to the laboratory directors who are more facile with information with respect to stability and the role that glycosylation will play with respect to assay standards. It's just that technical knowledge is beyond my realm of expertise.
Now, would you say that BNP is better than Nt-Pro BNP? Is it better in patients with kidney diseases?
The guidelines position both of those markers as being an equal choice, but my personal opinion, based on the head-to-head data that I've published and on my clinical experience, suggests that I think BNP is the superior test because of all the different manufacturer assays calibrate to a 100 picogram per milliliter cut point, and the observation that BNP has less renal interference than N-terminal Pro BNP. Now, in the setting of renal failure, BNP does go up, but it's not as highly dependent on renal function as N-terminal Pro BNP. Both can be measured in the setting of kidney disease, but we have to reset our cut points. So with BNP, we know, for instance, in the setting of chronic kidney disease, that the cut point really is probably about 200 picograms per ml. That's for patients who have an elevated serum creatinine but are not on dialysis. For dialysis patients, we know that that BNP level, even in the absence of heart failure, will be about 800 picograms per ml. With N-terminal Pro BNP in the setting of non-dialysis chronic kidney disease, there really is a substantial range of values that I don't think N-terminal Pro BNP is really interpretable. And then on patients on dialysis, I would not suggest that anyone have an N-terminal Pro BNP value. I don't think it can be interpreted.
Thank you. And I want to remind our audience members that any questions not answered today will be answered via email. We have time for a couple more questions. Our next question is, are BNP and NT-Pro BNP used in the same way, example, the same cutoff for both HF with preserved EF and HF with reduced EF?
No, they're not. I can tell you that with BNP and heart failure with reduced ejection fraction, the cut point is 100 picograms per ml, and there probably is an uncertain zone from 100 to 500 where we could find some cases to debate. Over 500, all experts agree that that's very consistent with heart failure. In heart failure with preserved ejection fraction, that there's a tighter dynamic range. And again, the cut point is still 100 for normal. However, once we're above 100, that becomes increasingly consistent with a diagnosis of heart failure with preserved ejection fraction. And we don't see levels nearly as high as we do with heart failure with reduced ejection fraction. With N-terminal Pro BNP, there's really no good guidance with respect to the range. The range could be as low as 125 picograms per ml as a cut point, all the way up to well over 2,000 as a cut point. So N-terminal Pro BNP has to be used as just kind of a relative guide and is not amenable to cut points or cannot discern between heart failure with reduced or preserved ejection fraction.
Thank you for that. And how does BNP actually affect HF?
Well, BNP is secreted, and it relaxes blood vessels, so it relaxes tension in the left ventricle. All of that's thought to be favorable in heart failure, and it stimulates the kidneys to excrete salt and water, and so it's diuretic, and so that's favorable. But what the listeners should appreciate is that there have been exhaustive studies of synthetic BNP made and given back to humans, and we can achieve about a plasma concentration of about 3,000 picograms per ml. And while patients feel better while getting the BNP infusion, it has not reduced mortality or reduced hospitalization. So we think BNP is probably better as a blood test indicating what's going on, but it's not a very powerful form of therapy.
Thank you. And what specific pathways in patients causes increase in BNP?
The major cause of increased BNP is wall tension. So in the inside of the heart, when there's more tension as the heart begins to fail, that tension on the cardiomyocytes and the full thickness of the heart tissue stimulates the cardiomyocytes to start producing the hormone. So the muscle cells in the heart are not only muscle cells, but they're also endocrine cells. And in response to wall tension, they produce BNP.
Thank you very much, Dr. McCullough. Our next and final question that we have time for today, we have noticed lymphocytosis, reactive lymphocytes in some of our code STEMI patients. Is there a connection between lymphs and heart failure?
Well, there's definitely an immune reaction in the setting of acute coronary syndromes and heart failure for sure. So it's understood, for instance, that there can be a white blood cell count elevation in the setting of an acute coronary syndrome. And in fact, in the setting of a heart attack, after about 4 days, there's quite a few granulocytes and some lymphocytes that are seen in the heart tissue itself. As we're getting patients more prompt treatment for myocardial infarction, there's probably less of an immune response. But as the question implies, there is a link between the immune system and the cardiovascular system, both in acute coronary syndromes and in heart failure. And so that future link between these two systems is really being explored from both a diagnostic and therapeutic perspective.
Dr. McCullough, we actually have time for one more question, and it's a great question to close with. Based upon your clinical expertise, what do you believe in the future of heart failure and biomarkers? It's a two-part question. And what areas need improvement or research to improve patient care?
My future view in heart failure, since we have so many therapies, particularly heart failure with reduced ejection fraction, is that the future is what's called personalized medicine, that we'll measure a whole array of biomarkers in heart failure patients, and then we're going to tailor the medical therapy to the biomarker configuration that each patient has. We've already attempted one small trial in this area and continue to work in this area, and I think therapy can be tailored to what the biomarker elevation configuration is in each patient, and hopefully that'll lead to improved outcomes. What we found out now that there's so many drugs in heart failure that we can't use them all at the maximum doses. So we have to prioritize one drug or another, and we have to prioritize not only the drug but also the dose. And the only way to do that, the rate limiting step is typically blood pressure and tolerability of these drugs. The only way to do it is to be guided by biomarkers. So I see that as the short-term future is personalized medicine. Long-term, I think certain biomarkers will be determined to be directly pathogenic, and those directly pathogenic biomarkers will be subject to therapies that lower them to improve heart failure outcomes. Like LDL cholesterol is directly pathogenic in coronary heart disease. We directly lower LDL cholesterol, we improve outcomes. Just like hemoglobin A1C is a very good proxy for the pathogenesis of hyperglycemia in organ disease, and we lower hemoglobin A1C, we improve outcomes. I think we're going to find some of these pathogenic markers in the future. One of them may be Collectin III right now, and if anti-Collectin III therapies are developed, it's possible they can improve outcomes. But I see that as the future. Biomarkers really have a promising role in heart failure as a syndrome. And I'll let that be the last word and let you close it out.
Thank you, Dr. McCullough, and thank you very much for your important research. I'd also like to thank the audience for their participation today and for joining us on this webinar. And I'd like to thank our sponsor, Abbott, for underwriting today's educational webcast. This webcast can be viewed on demand through September 2018. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.